O'Connell is her name is Natasha. She's a pediatrician by profession. She is a general pediatrician working for the Western Cape Department of Health, which is a district hospital in Cape Town. She's an honorary lecturer for the pediatric department at Stellenbosch University and oversees the pediatric registrar training in Khayelitsha. She has served her community since the hospital's inception in February 2012, and Khayelitsha District Hospital runs a very busy pediatric service with around 3,500 admissions per annum. There is high burden of children with infectious diseases, specifically in this area. During the peak diarrheal season, Khayelitsha has the highest incidence of diarrheal disease within the Cape Town metropole and the highest number of diarrheal admissions outside the tertiary centers. She's also working closely with the community to reduce mortality due to diarrhea. That is a priority. Dr. O'Connell, once again, thank you so much for joining us. I'm handing over to you. Can you please share your screen with us? And then I'm handing over. While we are waiting for Dr. O'Connell to share a screen, please note, participants, that you are able to communicate on the chat. You are also requested that if you have any questions, to please post it in the Q&A section. By that way, we will be able to trace your questions and the answers given afterwards, which we will use then to create a document that is a document that we can email to you so that you have that as a reference to refer back to. Thank you, Dr. O'Connell. I'm handing over to you.
Thank you, Magda. And I'm just keeping my camera on to say hello to everybody. I'm going to close the camera now and then move on to sharing my screen.
Hi, Doctor. We can see your presentation very well. Over to you.
Okay, thank you. So thank you very much for the opportunity to speak about this very important topic. I'm looking forward to learning from everybody who's participating today. And I'm hoping that together we can look at ways that we can close the gap in diarrhea-related mortality. I know Magda told me that a lot of the people who are joining the webinar today are working for the Department of Health in different parts of the country. We're very interested to hear how you are managing diarrhea disease and addressing these gaps where you work. So please, as we go through the presentation, think about your local setting and how one could apply all these things. So just to give you a brief overview of what we'll talk about, we're going to have a look at global as well as local perspective in terms of diarrhea disease and diarrhea deaths, a little bit on the definition and etiology, and then specifically at looking at what could we do to close the gap, which are based on the WHO and UNICEF strategies, and then go into a bit more details on recommendations for treatment, talk a bit about prevention, and then I'll share just a little bit about our local experience over the last 10 years. So we know diarrhea remains the second most common cause of death among children under 5 globally. This means that nearly 1 in 5 child deaths and about 1.5 million each year are due to diarrhea. And diarrhea kills more young children than AIDS, malaria, and measles put together. Most of the diarrhea deaths actually occur in sub-Saharan Africa and South Africa, and you can see the very red areas in the global map, which is very small in the corner. So although the total number of deaths globally from diarrhea disease remain high, the overall mortality rate has steadily started to decline over the last few decades. And the decline, especially in developing countries, is largely due to the use of early and appropriate oral rehydration therapy, as well as improved nutrition and water sanitization methods. The incidence of diarrhea disease is declining a lot more modestly though. And if we just briefly look at what's happening locally, diarrhea and pneumonia are persistent major causes of death in South Africa, but we have seen a slight decrease in the death rate from diarrhea disease as of 2008. But I'm sure you will all know in your experience, we certainly do see diarrhea is a significant burden in terms of what our clinics manage, and certainly in the area where I work, infectious diseases and specifically diarrhea with dehydration is still a very high priority for us. So looking at the definition, we know that diarrhea is defined as an increased frequency and volume of stool and a decreased consistency, and one requires at least 3 loose stools in a 24-hour period to make the definition. Acute gastro produces dehydration through vomiting and then loss of fluid into the gut through osmotic and secretory mechanisms. Nutritional malabsorption then also occurs through varying degrees of damage to the intestinal brush border. And this is aggravated by intestinal hurry, and this can also aggravate osmotic fluid loss. So then dehydration ensues, and most deaths from diarrhea are due to dehydration, hypovolemia, and potentially shock. And we see that children, especially under 5, because of the body composition and the amount of body water and the immaturity of the kidneys, are much more susceptible to dehydration from acute gastro, and specifically malnutrition as well are very susceptible. And also important to remember that aside for the risk of dying, acute and chronic gastro also cause a significant nutritional insult at a very critical time in growth for these small children. So we always need to keep nutrition in the back of our minds when we're thinking about managing children with diarrhea. We do see diarrhea has a seasonal variation, usually worse in the summer months, and in the Western Cape we have a peak. So I monitored our diarrhea season quite closely from November till May of the following year. In terms of etiology, most acute diarrhea are due to infective pathogens. The most common 4 pathogens that we see in the developing world are rotavirus, Cryptosporidium, enterotoxigenic E. coli, and Shigella. This is a slide I wanted to show you, which speaks to closing the gap, an integrated global action plan for the prevention and control of pneumonia and diarrhea from 2013. So pneumonia and diarrhea remain major killers of young children, thought to be preventable causes of death. And together, these diseases account for 29% of the deaths of children less than 5. So more than 2 million children every year. And I think what wants to highlight on the right-hand side is that many proven interventions actually exist. And children are dying because services are provided piecemeal, and those most at risk are not being reached. And use of effective interventions remains too low. For example, if we look at exclusive breastfeeding, 39% of infants less than 6 months are exclusively breastfed. And we know that this is very important in terms of prevention of diarrhea and pneumonia. So I think we know what we need to do to address diarrhea, but the implementation of strategies that have been proven to be effective is what is difficult. Did you know? So I've put a few of these questions throughout the presentation. Oral rehydration therapy and continued feeding is a life-saving treatment. But they estimate that only 35% of children with diarrhea in developing countries actually receive oral rehydration therapy and guidance to continue feeding. And there's very limited data to show that there's been very little progress since 2000. So WHO and UNICEF actually set up a comprehensive strategy, a 7-point plan, which focuses on nutrition, health, and environmental factors that all play a role in preventing and treating childhood diarrhea. And I think the reason why I show this slide is that when we think about treating children with diarrhea, there are multiple components to the strategy, and all of which are very important. So the one part of the strategy focuses on actually treatment of the disease, for which we have very well proven interventions, namely your oral rehydration therapy, zinc, and to continue feeding. But on the other side, we need to look at what can we do to prevent and reduce the burden of childhood diarrhea in terms of primary prevention to prevent disease transmission. So vaccine, hand washing, improved drinking water supply, and community-wide sanitation. And secondary prevention in terms of breastfeeding, vitamin A and zinc. And then also to look at nutrition, so reducing the risk factors for severe diarrhea disease and death from diarrhea, so looking at stunting in the areas where we are. So did you know breastfeeding is critical to both the prevention and treatment of diarrhea? Infants who are exclusively breastfed for the first 6 months of life and continue to be breastfed until 2 years and beyond develop fewer infections and have less severe illness, including diarrhea. So as little as 39%, as we said earlier, are breastfed worldwide. So now we're going to move on. So then we have very clear universal recommendations of what we know will work well for diarrhea. The top three being then our oral rehydration fluid, zinc, and feeding. We're going to then just talk through a few others. So in addition to that, rapid clinical assessment of circulation, hydration, and comorbidities is essential in children who present to any facility or healthcare setting that have diarrhea. Children have to be assessed immediately. The other important thing is that shock needs to be identified immediately. We're referring then to intravascular dehydration, and this needs to be treated appropriately. Rapid rehydration within 4 to 6 hours with hypertonic solutions is a recommendation and safe. And rehydration via the gut, where we can actually rehydrate orally or via a nasogastric tube infusion, is a strong universal recommendation, as well as continuing breastfeeding through the episodes of reintroduction throughout, and then the episode, and then early reintroduction of full strength feeds and zinc therapy. So just to talk a little bit more about clinical assessment. So we all need to have a system in the facilities where we work and the surrounding facilities where children can be clinically assessed immediately on presentation. And it's very important that we try and identify shock, and then also assess the hydration status of a child, if they are dehydrated or not. And just as I go through, I'll talk through sort of some of the lessons learned. So some I think of the more trickier cases to assess for dehydration are children who are very well nourished, maybe sort of erring on being on the +2 or the +3 Z score. They often can have quite a lot of losses and actually have lost quite a lot of weight without having a lot of signs of dehydration. So I think sometimes identifying the signs of dehydration are easy, and sometimes they are a lot more subtle. And certainly cases of hyponatremia, it's easy to underassess your hydration status. Other red flags just to be aware of is lethargy. We'd always be concerned if you're lethargic that either you are shocked or severely dehydrated. It wouldn't be a sign of mild to moderate. Tachypnea is also something to be aware of, which means you have an increased respiratory rate. And children do sometimes present with a metabolic acidosis, which increases your respiratory rate. And it's easy to then sort of automatically, with the increased respiratory rate, think they fall into the pneumonia category. So a child who comes in with a history of diarrhea but actually is tachypneic should always be considered to have a metabolic acidosis, and maybe would be quite dehydrated, even though they might not have all the clinical signs. And this we do see, especially with small babies who have very large watery stool losses quite rapidly. And then just always to remember the edematous child, who is a little bit more difficult to assess and would suggest that they have severe malnutrition. So in terms of assessing for circulatory shock, Important things to look at would be their level of consciousness. Usually they have depressed level of consciousness or are very lethargic. Try and feel their pulses. Their peripheral pulses are often absent, weak, thready to feel, difficult to feel. Sometimes it's useful to feel their hands and their feet, which are often cooler. And if they've got nice warm hands and feet, probably you can feel the pulse as well, but otherwise you'd take some time to see if you could feel a pulse. And the capillary refill time would be more than 3 seconds, and often the heart rate is very fast. So a child can be shocked, important to remember, without having signs of dehydration. So very small babies that have very large watery stools that they lose very quickly might not have had time to develop the clinical signs of dehydration. But yes, you can also present with clear signs of dehydration as well as shock with poor perfusion. So these children all need to have their glucose checked. We need to have a look at their nutritional status, and then start instituting treatment for shock, which we'll talk about in a minute or two. The next step would then be, once you've either excluded shock or you've successfully treated shock, is then to assess your hydration status. Weight can be very useful with your hydration status if that is something that is available for you to do. And it obviously is most helpful if you've had a recent normal weight on the child, which will be helpful in helping you estimate whether the child has lost 10% or 5% of their body weight. We are taught to look for the signs of dehydration and then attempt to classify a child as having some signs of mild dehydration. They would be, the child is restless or irritable, drinking very eagerly and thirsty, not passing as much urine, the mouth is dry, they don't have tears, and the eyes might even be a little bit sunken, and the skin pinch goes back slowly but within 2 seconds. And then severe dehydration would be a significant weight loss with very sunken eyes, a lethargic child, and skin pinch that goes back very slowly. I think in practice, it's easy to sometimes misclassify between some and severe, moderate, mild, and severe. And I think one has to realize that assessing your hydration status is an estimate, and it's the important thing is it's giving you a guideline on how to start, where to start. And the important thing with children with dehydration is that they should always be reassessed, because we do sometimes underassess and we do sometimes overassess. And then if we look a little bit at treatment, we're going to talk about treating shock, rehydrating, optimizing nutrition, and then it supplements and special situations. So immediate treatment of hypovolemic shock is recommended with either intravenous fluid, and if you're unable to put in an intravenous line, with intraosseous lines, if your attempt is unsuccessful within 2 tries of 15 minutes, that's an APLS recommendation. The fluid that we then give to reverse the shock is 0.9% sodium chloride or Ringer's lactate, and 10 mils per kilo are given over 20 minutes. So there has been a move towards giving smaller volume boluses over slightly longer periods of time, and to keep reassessing children because of underlying comorbidities and the facts that we often see children that have multiple reasons for being shocked. So in children where there's clear hypovolemic shock, you've seen the watery stools, they're very dehydrated, one could probably give as your first bolus a slightly bigger volume of 20 per kilo. But when there is underlying malnutrition, when you suspect underlying sepsis, the etiology for the shock is multifactorial, and smaller fluid boluses are safer. The important thing though is that shock should be treated until it is reversed, and care should be escalated as needed. So after 40 mils per kilo, it is always recommended that you discuss with the senior and consider inotropes if that's available to you. And also to monitor the child. So after every bolus of 10 mils per kilo, one should be looking for signs of reversal. So your heart rate comes down, your pulses are easier to feel, the capillary refill time is improved, the child is more awake and alert and less lethargic. It's It's always important to document if you can feel your liver, and then monitor the fluid that you've given by increasing or non-increasing size of your liver. And also you want to look for signs of overhydration, that potentially you've given too much fluid. And those are important to monitor for. So I think the big message with treating shock is don't leave the patient, and continuously reassess them and call for help. And then if we go and move on to then treating dehydration, we're first going to focus really on enteral rehydration. And this was life-saving in the 70s and 80s, oral rehydration therapy. And it has long been recognized that in almost all cases of gastro, the intestinal mucosa retains the ability to absorb water and electrolytes in the presence of glucose, providing the basis for the oral rehydration therapy. So international recommendation is that hypertonic solutions by the oral route be used, not only to prevent dehydration, but also the oral and nasogastric routes can be used to treat mild and moderate dehydration when you already have signs of dehydration present. So WHO moved to the low osmolality solution because they showed that the stool output and vomiting decreased by about 20 to 30% respectively, compared to the original ORS formulation. And they also had less unscheduled intravenous therapy needed in these children. So in South Africa, I know we use a combination of things. Sometimes facilities are using commercially available sachets that can be mixed with water, or we are recommending that people use the sugar salt solution, where we mix 8 teaspoons of sugar with half a teaspoon of salt. So this fluid can then be given orally, which can be drunk via a cup if the child is able to drink, or via a nasogastric tube infusion. It can be initiated much more quickly than intravenous therapy, and it is much safer. And we know that nasogastric rehydration only fails at about 5% of cases, and using the gut sort of shortens the duration of diarrhea, and hospital stays are then shortened. Oral rehydration is safer, is specifically in children who are malnourished and children who are hyponatremic, so that we avoid rapid shifts in the sodium. And as a rule, intravenous fluid should really be reserved for cases of severe dehydration, shock, and very complicated children. So with oral rehydration, whether it's given orally or via a nasogastric infusion, we can actually treat a lot of children with mild to moderate rehydration safely and effectively. The important thing, as we've said before, with reassessing your shock patient is, as with dehydrated children, is that we need to regularly reassess our treatment. So I'm going to talk a little bit about rapid rehydration. So rehydration of children with mild to moderate dehydration over 4 to 6 hours has been shown in a number of settings to be both effective and to be safe. And this is a protocol that we have adopted in the Western Cape since I've been at Khayelitsha, and our provincial guideline is to, if there are no contraindications, to attempt to rehydrate children rapidly. Reasons for this are to realize that a dehydrated child actually needs to be returned to their normal state of fluid balance as soon as possible. We know that dehydration promotes vomiting, and vomiting will then delay reintroducing feeds, and feeds, especially once you are taking semi-solid feeds, help reduce the stool output and shorten your time to recovery, which means that once you're feeding, you decrease the negative energy balance, and the negative energy balance is what has the long-term consequences for a child, especially a malnourished child. So it has implications for nutrition, and dehydration also leads to other complications such as renal failure, and it reduces your length of hospital stay. So the chance of hospital-acquired infection and other medical misadventure that arises can hopefully be averted. Rapid rehydration can be done with oral rehydration solution or sugar salt solution. It can be done using a cup. It can be done using a nasogastric infusion, and one can actually also do rapid rehydration using intravenous fluids. So our guideline with emergency medicine Cape Town guideline is that we use, in cases of moderate or some dehydration, where there's less dehydration, then we start with oral rehydration fluid, and we give 20 mils per kilo per hour for a period of 4 hours, and then we reassess the child. Severely dehydrated children, the recommendation is that we actually start with intravenous fluids, half DD. Is the fluid that we use at 20 mils per kilo per hour. But we do often say to clinicians working in the periphery, if they're struggling with intravenous access, that there are very few children that you can't treat with oral rehydration therapy. And an option is to insert a nasogastric tube, which should be relatively easy if you cannot put up an IV line in a very dehydrated child, and start continuous nasogastric infusion, and that will improve the child's hydration status. And one can always move to inserting an IV line a little bit later, or when the child has reached a center where there's someone who's able to do that. So the important thing is, once you've started your rehydration, especially if you're using the enteral route, is to monitor the child at 2 hours to see if they are vomiting and they tolerate the nasogastric infusion or the oral. So the clinic sisters practice this using a cup. It's the INCI treatment guideline. If there's some dehydration, the mom sits with a cup, her oral sugar salt solution, and every hour she's asked to give 20 mils per kilo for a period of 4 hours. And she should be regularly assessed every 1 to 2 hours. And specifically what we need to look for is the child able to actually drink the recommended volume, because if they're not able to drink it, they've failed. If they vomit what has been given, then one needs to look at, is the mom administering it as slowly as she should? We prefer that she gives small amounts via a teaspoon and doesn't let the child drink very eagerly, over distend the stomach and induce vomiting. So if the child fails this oral route, then the option is one could put in a nasogastric tube. And one might think, well, this is counterintuitive. The child's vomiting when we give a cup. Why should we use a nasogastric tube and not put in an IV line? And actually, when you run the oral rehydration fluid through the infusion set via the nasogastric tube, you get a very small volume coming through slowly. So it almost mimics you giving a half a teaspoon or a quarter teaspoon continuously to a child, which is very labor intensive. And one can actually successfully then rehydrate them. So often we would move, if you fail your oral trial, is to move to a nasogastric infusion if they've got mild to moderate dehydration. And that actually works very well. And then also to review, if you've chosen the intravenous route for severe dehydration, to assess that the child is improving clinically. If there's no improvement after 4 hours, the assumption is that your fluid loss is likely greater than what you've assessed, and one can actually repeat the rapid rehydration regimen. So contraindications to using this rapid administration of fluid is firstly shocked patients, because they should be treated for shock. Once shock is resolved, you can assess if there's any other contraindications to rehydrating rapidly. Children who are severely malnourished, so they are unable to tolerate this rapid influx of fluid. It could be dangerous for them, so we recommend not rapidly rehydrating someone who's severely malnourished or has a cardiorespiratory illness or a neurological comorbidity. And then children who have hyponatremia, we also don't want to drop the sodium too quickly. And then if you're less than 2 months or more than 5 years of age. Okay. And this is a picture of a child that we've now treated from the clinic. So what we've done in the area where we work, we have a district hospital and we have 10 clinics in the surrounding sub-district, and they refer into our hospital. And we've gone around to each clinic and we've tried to implement a system at each clinic where, once the IMCI strategy has failed and they've made a decision that they need to refer a child to hospital, that they can insert a nasogastric tube. And then they attach that to some kind of giving set, which has the sugar salt solution at the top. And this giving set is attached to a rate controller, so we can work out how much fluid we want to give. So if we have a 10 kilo child, they'll give 20 mils per kilo. So they'll give 200 mils every hour. then for 4 hours. And the great thing about this is that if there's any delay in transport, or if, for example, you work in an area where your clinics are very far away, or it takes time to get to the district hospital, then this is a very effective technique to actually start rehydrating a child who then would have almost had 4 hours of rehydration by the time, potentially had more 4 hours of rehydration by the time they actually reach hospital. We've also, in periods where we've had very busy seasons and run out of special machines that can give oral rehydration fluid continuously, used these kinds of systems. Over the years, we have had difficulty as there is a move to having enteral feeding systems, which are not compatible with intravenous feeding systems. And this is for safety reasons. And eventually, at some point, all the connectors will not be universal. They will either be ENFIT for enteral feeding, or they will be intravenous connections. So over the years, we have adjusted and adapted our systems. Other things that you could do is even though half DD is recommended for intravenous use, it has a similar constitution to oral rehydration therapy, except for the sugar content. So as a last resort, we do sometimes actually use the intravenous half DD connected to a nasogastric tube, which can be given enterally. Okay, so that's just talking about the very number one recommendation for treatment, is that we have a good system in which we can give oral rehydration therapy or intravenous rehydration therapy. And then important to always counsel your colleagues and moms to continue breastfeeding during the whole process, and that early reintroduction of feeds is recommended. So feeds, especially semi-solids, reduce stool output, they shorten your time to recovery, and they prevent malnutrition. So we should never stop breastfeeding. And we would actually then, once we have done the initial 4 hours of rehydration, then reintroduce feeds. We also recommend that they don't dilute their formula, and just to be aware of the malnourished child, the protocols for that is that they should actually be fed immediately on arrival to any kind of emergency center or clinic. It prevents hypothermia, hypoglycemia. We should be watching their glucose. So they especially should be fed as well. And also we would only withhold feeds if there was significant ileus, low potassiums, and then try and reintroduce feeds as quickly as possible. And once we've treated the acute episode, I think just to always bear in mind that this is the significant nutritional insult on a growing child, and an extra meal a day at discharge, as well as close monitoring weekly, really, to ensure that this child recovers. And then zinc. We all need zinc. Zinc is essential for overall health, growth, and development, including immune function. And there's a deficiency specifically in developing world. Zinc stores are also depleted during acute diarrhea. So if given, they also say that parents are less likely to try and get other antidiarrheal medications, which are not recommended. So zinc reduces the duration and the severity of diarrhea in persistent and acute gastro. It has greater benefit if you have malnourished. The evidence under 6 months of age is a bit weaker, but it is a recommendation for us to use it, and those are the doses that we are giving for a 2-week period. So did you know zinc tablets are still largely unavailable in most developing countries, although their effectiveness in reducing severity and duration of diarrhea episodes is well known. Blood and other tests are usually not required in managing acute gastro. In certain cases that are very unwell, shock and severe dehydration, we do limited investigations, checking a glucose, renal function, electrolytes, and anyone who has signs suggesting an electrolyte imbalance. So a very floppy child who might have a very low potassium, or a child who's fitting potentially from a low sodium, and children who appear sicker than what the dehydration suggests. We also would screen for infection in very small children presenting with diarrhea under 3 months, children who are malnourished. And just to remember that if children do present with fever, one should at least always check a urine dipstick to ensure there isn't and do a clinical exam to look for a focus other than just gastro. For dysentery, one could send a stool MCNS, but preferably before antibiotics are initiated. Otherwise, the yield is very low. Otherwise, we treat empirically for what we suspect are the common causes. And in chronic diarrhea, these children should really always be referred. And there are a few things that we need to look at and a few investigations that need to be done. Other minerals and electrolyte supplementations. Vitamin A is a critical preventative measure, and we know that it has significantly reduced mortality in children, and this is closely linked to diarrhea and measles deaths. So if our children are regularly attending facilities, they should be regularly getting vitamin A doses, but an extra dose could be given during an acute infection, especially if there's malnutrition. Potassium chloride, we don't routinely give it for outpatients, we give it for inpatients. If they're shocked, we wait for their renal function and their potassium. I think just to be aware that sugar salt solution doesn't have a lot of potassium in compared to the commercially made oral rehydration therapy. So a child who's had diarrhea for quite a long time and then starts vomiting or is very weak and lethargic, you would be concerned about the problem with low potassium. So vitamin A significantly reduced, we've actually discussed this already. So there are various guidelines to treat your electrolyte abnormalities. If you have very low potassium, we would go the intravenous route, monitor them very closely, and try and correct the potassium as rapidly as one is allowed to in the first few hours of life, and then be able to continue enteral treatment and feeds. And potassiums of 2 to 4 are then treated orally. So to be aware, we do see a lot of children with hyponatremic dehydration. This could be because of the type of diarrhea that they have, but also sometimes because of incorrect mixing of the sugar salt solution if they give too much salt. The concern with it is that it reduces your clinical signs, so they might not look as sick as they appear, or as dehydrated as they appear sick. They need to then rather be rehydrated much more carefully over a 24-hour period. You can use half DD or oral rehydration fluid. Oral rehydration fluid is preferred, and they need to be intensively monitored to ensure that the sodium doesn't drop by more than 1 to 2 millimoles every hour. And complications with dropping sodiums too rapidly or not managing these children well are cerebral edema, venous sinus thrombus, possibly seizures. So sometimes we have children with very complicated and severe disease from diarrhea, and they require definitely high care monitoring and transfer if you work in an area where that is possible, and that would be any child who has shock, because they are much more likely to go into shock again in the next 24 hours. And then if they have an altered level of consciousness despite correcting the shock, any child who's got severe malnutrition with dehydration needs very close monitoring and adjusting of fluids. And then if you're suspecting something surgical, like your bowel stain vomiting or abdominal distension, and we probably do see one intussusception almost every year in our diarrhea wards. They present maybe with a bloody stool, but they have extreme abdominal pain, not that much diarrhea. And so just important to be aware that those things do sneak into the ward. And then children with convulsions or severe electrolyte abnormalities. So what about anti-diarrhea agents? So they are not recommended in infants and children. They don't actually address the underlying cause. They make no difference in terms of addressing dehydration. And there's a risk of toxic megacolon in patients treated with dysentery. And loperamide does have a higher risk of serious adverse events, ileus, lethargy, death, even at therapeutic doses, and the manufacturer doesn't recommend under 2 years. So it should really be restricted to specialists in hospitals. Antiemetics, they can be used. Ondansetron single dose does reduce vomiting and help facilitate oral rehydration therapy and the need for IV fluid. There's limited research with other antiemetics, But the important thing to remember is that vomiting is usually due to local factors in the gut or starvation. And often they do respond to simple fluid therapy and rehydration as a first step. Ondansetron is also not widely available in the government sector, and usually is reserved for oncology patients getting chemotherapy. So probiotics, the good or friendly bacteria that can help fight against harmful microbes causing diarrhea, help the gut fight them and reduce inflammation. Some multiple systematic reviews did demonstrate a modest reduction in the duration of infectious diarrhea. Recent Cochrane review has said that they don't feel that it's made a significant difference in the number of people who have diarrhea lasting 48 hours or longer. And this was based on large trials and a low risk bias. Should we treat with antibiotics? Not routinely. Dysentery or dehydration in very small children under 3 months, one would always screen and look for infection. If you're febrile, a reminder to look for a source, look for a UTI and treat that. And a high risk for bacteremia, those children should always be screened for infection. So your immune compromised children, HIV, severe malnutrition, less than 3 months. And then we do sometimes identify specific etiologies that need specific treatment, like Giardia. So just a few words on chronic diarrhea. And I think that just because this is so important in terms of the long-term consequences with severe malnutrition and the risk for mortality. A definition is officially loose and watery stools occurring at least 3 times a day for more than 14 days. Stool consistency is more important than the stool frequency. And this is something that we do see in communities where children are very malnourished, immune compromised, and there's poor socioeconomic circumstances. So I work in probably one of the poorest areas in the Cape Town metro. And so we see a lot of malnutrition, a lot of immune compromised patients and extreme poverty, which I'm sure is the same for a lot of areas that you guys work in. So the causes of chronic diarrhea is multifactorial. It can be infective. So there's another organism causing the diarrhea and not rotavirus, not just a virus. And those then need to be potentially treated with an appropriate antibiotic. The other thing to look at when you're assessing a child with chronic diarrhea is if this is not reinfection. And often we've now spoken about the preventative strategies earlier, and we'll look a bit at prevention in a few minutes. But are they going home to the same contaminated water source? Are they still feeding their baby with the same unsterilized bottle? And that is not really the reason for, are they getting better and then becoming reinfected because we haven't addressed the problem at the source. And then we do see diarrhea presenting as a symptom of underlying chronic disease like HIV or TB. If they are malnourished, the gut is not functioning optimally, it's not able to absorb the milk optimally, and those children definitely need in-hospital care. And we do see that urinary tract infection can be a common precipitant of ongoing diarrhea. So children with ongoing diarrhea should be screened for a UTI. We know that an infection with acute viral gastro can lead to a transient lactase deficiency because it destroys the brush border of the gut. And often these children will have ongoing diarrhea, especially when they have something that contains lactose, like their milk feed. And for those children, we can test for it, or if not, give an empiric short course of a lactose-free feed and look for a clinical response, and then slowly reintroduce the lactose feed. So this usually recovers in 2 to 4 weeks. And we obviously do want to address this because it has an long-term impact on nutrition. And then other things to consider are bacterial overgrowth or other more rare causes on our side for chronic diarrhea, like celiac disease, cystic fibrosis. So the approach to chronic diarrhea is that they should really always be referred for further investigations. And certainly in the community I work in, I feel a bit uncomfortable if the referral is only at 14 days, even though I know that is the textbook definition, especially if the child is having significant losses, if the child is underweight and malnourished and might even have some signs of dehydration. So we actually educate that there's a lot more awareness around it, and that people think of monitoring them very closely and referring them in earlier. Certainly, we always manage them as inpatients if they're dehydrated or they're malnourished, and we look for infection. We treat the infection if we find it. We consider temporary lactose-free diet. We support their nutrition, and then they need to be followed up very closely. So just lastly, in terms of risk factors for mortality and just lessons that we've learned, and some of these things I have alluded to, so I'll try not to repeat them. I think sometimes at clinic level, it's difficult to always do the correct assessment with moderate versus severe. And I suppose our message to our staff is that if the child doesn't respond, or you're concerned that there are any signs, then rather send those children into hospital. And we are a lot more careful in children who are under 3 months. So I mean, we know that the biggest killer is neonates, and we do see neonates dying from gastro and pneumonia. And IMCI actually allows, if there's some dehydration, it allows for you to rehydrate very small babies in the clinics and then send them home for review in 2 days. And in our sub-district, we've actually asked that very small children actually rather be referred to the district hospital, where we can monitor them closely, and that they really only manage. So small babies with diarrhea are actually then referred in and monitored much more closely. Yeah, and I think we've spoken about the others. So just be aware, anyone who's had previous admissions or multiple clinic visits, we should have a low threshold to rather send those children in, as well as always children who have underlying comorbidities. Because I think sometimes we see a child and we can treat their dehydration or the gastro, but if they also have a little bit of failure to thrive, and they also have maybe a little bit of a cough, once there are multiple comorbidities and growth problems involved, those children, even though they're not necessarily severely dehydrated, should rather be properly managed, I think, or sent to a center where they can be assessed and followed up and closely managed. Okay. And then prevention. So we've only got one slide on prevention. And prevention really, as we alluded to earlier, in terms of the WHO and UNICEF strategy, is to look at improving nutrition and overall health, because we know that children who are well nourished and who are healthy are less susceptible to illnesses like diarrhea, getting very ill from them, and certainly dying from them. So if we can improve the overall health and nutrition in children, then we've done a lot in terms of our fight against the morbidity and mortality from diarrhea disease. So rotavirus vaccine in 2009, WHO recommended that this should be adopted by all national immunization programs, and South Africa has done so. Measles vaccine has also contributed to the overall health. And then, very importantly, early and exclusive breastfeeding. And I think in South Africa, we have a long way to go, certainly in the sub-district where I work. And I really think that we need to think of new strategies and new ways that this actually can be a focus event and a focus point. And this would address more than just diarrhea deaths. Vitamin A, as well as using oral rehydration fluid as prevention, so not just treatments, and always remembering that parents should realize that that is a medicine that they should use. And then if we look at improving sanitation and hygiene, so safe water, adequate sanitation, and proper hygiene are too often forgotten foundations of good health. And I think as people who work with children and who are promoting child health, and wherever you find yourself, I think, you know, the onus is on us to really advocate for improved services, improved sanitation, improved water supply, I think, for the communities and the children where we work. And this is an integral part of really making a difference in certain communities. So improved water supply, looking at the quality. So we need to engage with the other sectors working in our areas. And then hand hygiene. So, I mean, we know this is something that we can teach parents. Hand washing with soap alone can potentially reduce the number of diarrhea cases by over 40% just by adding soap. And in our area, we sort of use something that's called the squeezy bottle, where they just take a 2-liter bottle, a little bit of they put clean water in it and a little bit of sunlight soap. And it's attached to a pipe that they can use and run at a low rate when they need to wash their hands under it. But just to think of ways in which people can practically wash and clean their hands at their homes and in their communities. So I just wanted to end in the last 2 minutes, really, just to tell you a little bit about our local experience. So as Magda alluded to earlier, so Khayelitsha is actually has a population of 0.5 to 1 million, depending on which census you read. And we have a high burden of very small children in that area. So it has the highest incidence of diarrhea disease within the Cape Town metro, and a lot of diarrhea deaths, a very, very poor area. So Western Cape implemented a metro-wide or provincial-wide diarrhea strategy around 2007 or 2008, I can't remember exactly. And so this was a multi-sectorial, included primary health care, community-based services, acute hospitals, environmental health. It was labor-intensive in terms of monitoring diarrhea cases and reporting on them, and then actually doing early reporting and monitoring of diarrhea deaths. And if I just briefly explain, so it was sort of a way in which we follow the recommendations from WHO, where you actually have a broader approach to making a difference for children with diarrhea disease. So at primary healthcare, they would follow the IMCI guidelines. All children would be reported with diarrhea disease. And if they had some dehydration, they would be rehydrated at the clinic. And if successful, they would be sent home with their oral rehydration therapy and zinc. And the community-based workers would be asked to go and visit them and then look and do further education, look at the water supply, look at the general hygiene in the health, and check up on the child. And the child would then be reviewed in 2 days at the clinics. And then any child that had severe dehydration, the primary healthcare clinic would then refer to hospital, and all those children would then get environmental health referrals. So they would go home and look at the sanitation, hand washing, and the situation that the child would go back to prevent another episode of severe dehydration. So this plan was rolled out slightly differently within each sub-district, who would then meet regularly, and then they had monthly meeting and data monitoring. And we did see a significant reduction in diarrhea season deaths under 5 years within Khayelitsha sub-district. You can actually see how it dropped quite dramatically. And also we've had significant decrease in the number of children requiring admission with gastroenteritis. So the assumption is that they were severely dehydrated. And we've seen a decline in that over the years. And then, but finally, just to show, unfortunately, some data, I think, from our most recent season, so November to May 2020. And even though we've seen very few deaths in hospital from diarrhea, so only 5 over actually all the hospitals in our Cape Town metro, we've seen sort of 85% of the diarrhea deaths outside of hospital. And this is a pattern that we are seeing, even though in theory people are close to care and we have a hospital in a very poor community. We still have delayed access to care. We still have children presenting to the forensic services that have died from medical causes like diarrhea and pneumonia. And I think a lot of the things that have been put in place within the current epidemic that we're living in, I think it has taken its toll on primary health care. So I think we still have a lot of work to do in terms of what can we do to prevent diarrhea in the communities where we are treating children. Okay, and that's the end of my presentation. Thank you.
Thank you very much, Doctor. I appreciate it. It was a good reminder, and it was also good to get an update on what is the international, global, and the South African guidelines. We have a few questions, so Doctor, if you don't mind switching on your camera, then we can move over to the questions. Thank you for those that have posted questions. If there's still anyone that wants to post a question, you are free to do that in the Q&A section. For those of you that posted a question in the chat, we will try and get to that. If you are able to put it in the Q&A section, that will be fantastic. Good, Doctor, we are having a few questions about probiotics and the use of probiotics in the managing of diarrhea. We're having a question from Rendani. Rendani is asking, how safe is the use of probiotics in managing diarrhea in children?
I think if you have a look at the Cochrane review, there was nothing to suggest that probiotics are necessarily unsafe. There were certain strains that in some of the trials look to be more beneficial than other strains. So for example, lactobacillus is one of them. I think they just found that the evidence wasn't strong enough to necessarily recommend that it makes a significant difference. But it's not an unsafe thing to use. And that's just specifically looking at probiotics for children who have acute gastro. So not giving probiotics when you give antibiotics to prevent, sort of to keep the normal. I don't know, okay. You can let me know if that answers your question.
Yes, thank you, Doctor. Then Maria has asked, are you aware of any contraindications for the use of probiotics in immune-compromised children?
I'm not aware of any. I think it depends what kind of immune compromise you're talking about. So whether it be an oncology patient on immunosuppressive treatment. So yeah, I can't answer that question.
Good. Maria, we will also get more information and then we will get back to you about this answer as well. Thank you for the question. Doctor, the last question we have about probiotics is from, let me just get to that, is from Tembelile Malale. Tembelile is asking, how much probiotics can you give to a patient?
So I think that is very specific for the brand, and you would need to follow the guidelines of the manufacturer. And also the course that they recommend with acute gastroenteritis, and that it's safe for the particular age of the child that you want to use. I mean, unfortunately, we don't have probiotics available in the state, and I think it's because the evidence isn't strong enough for them to adopt it as a strategy as they would think, even though there are a lot more available and potentially becoming cheaper and more cost effective.
Thank you very much, Doctor. We have a question from Mignon Jordan. She's asking, with children older than 1 year that is stabilized but not able to eat, what type of enteral feed would be ideal? Would you use a semi-elemental that will be suitable, or should you wait until the patient is conscious to eat? And if not, for example, in a CP patient, what will you suggest?
So for a child that's had acute gastroenteritis, I mean, our goal is really only to withhold feeds for a very short period of time while we rehydrate them. So as we've said, if they were breastfeeding, we would allow them to carry on breastfeeding. So now you're saying over 1 year, so the assumption is they've been taking some kind of milk feed with probably some kind of semi-solid. So the recommendation would be then, as soon as you've rehydrated them, which ideally should take 4 to 6 hours, that you allow them to then feed as much as they can, just small amounts. If they can take a semi-solid food is what they recommend, that they think makes the best difference to shorten the course of diarrhea. I think, I mean, the milk feed would be, I think if the child is not severely malnourished, I think you could reintroduce the feed that they would normally use. I don't think there's no recommendation to necessarily change your feeds if you have a short episode of diarrhea, if you don't have underlying comorbidities.
Thank you,
I think
Doctor.
children who have cerebral palsy, who are on PEG feeds, you know, depending on where they're getting those feeds, it might be that they're, yeah, I mean, I wouldn't be able to give you a specific brand that I would recommend. I mean, sometimes we put them on a low lactose feed. For example, Pediasure has less lactose in it, but it's not lactose free temporarily, and then you would put them back onto their high calorie or richer milk feed.
Good, thank you, Doctor. We have a question from Masabati Mfolo. She's asking, how do you manage a child who vomits everything, and that is regarded as a danger sign?
I think if you think of the situation, so they're saying it's a danger sign, so hopefully they've come to your clinic. And then the first thing would be to look at the child and assess them, because if they're obviously dehydrated and shocked, you obviously want to address the shock. If they're not shocked, but they have some dehydration or a little bit of dehydration, is then to actually look at the reason for the vomiting. So is the mom maybe giving the oral rehydration fluid incorrectly? By that, I mean, they often, if they're mildly dehydrated, they're very, very thirsty, and they'll take a whole cup of water, swallow it, and then they just have a huge vomit. And actually to try and control giving, whether she uses a syringe or a teaspoon, to actually control giving the oral rehydration fluid slowly and see if that makes a difference. So this child obviously needs to be reviewed regularly. So you're going to try something, and so that's what we would normally do. And then if they are unable to tolerate that oral rehydration fluid, then we would move to, if you have the facilities available, to give a nasogastric infusion of oral rehydration fluid. So we put a nasogastric fluid in, a nasogastric tube in, and we run a continuous infusion. And the benefit of that is that you give the oral rehydration fluid very slowly, and often the vomiting is because they are dehydrated, and as you slowly start to rehydrate them, then you can often rehydrate them successfully using a nasogastric infusion and avoid intravenous therapy. But those children need to be monitored closely, and if they do continue to vomit on the nasogastric infusion, then one would move to intravenous rehydration. So depending on what setting you find yourself in, and if you are able to monitor a child or give a nasogastric infusion, otherwise they would have to be referred somewhere to where they can be monitored.
Thank you, Doctor.
But they can't go home until they've stopped vomiting, I suppose, at least for 4 hours, and manage to take rehydration fluid.
Good. Thank you very much. Doctor, we have a question from Hanneke Schroeder. She's working as a dietitian in private practice, and she's asking, can you give zinc supplements as an outpatient? Can you give zinc supplements to outpatients?
Yes, and that is part of the IMCI guidelines. So any child who presents to a clinic with diarrhea will get 2 weeks of zinc. So they get educated on using oral rehydration therapy. They check that they can take it, and then they give oral zinc for 2 weeks. So whether they dehydrated, not dehydrated, get admitted, don't get admitted, we give everybody zinc, and that will be outpatient and inpatient.
Thank you, Doctor. We have a few questions left and a few minutes. Marike Jordan is asking, what is the risk of overhydrating a child in a short period of time via nasogastric rehydration, especially for a child from a rural area where they do not manage to start an IV line and no intravenous line?
So it's actually very safe. It's much safer to use nasogastric infusion. And even when you do rapid rehydration, the risk is very low that you would overhydrate someone with enteral infusion. Because the body, it's not like overhydrating somebody with intravenous infusion. So it's actually a very safe way. And if you work in an area where patients are coming from very far, and you can teach sisters to put in the nasogastric tube safely and make sure that it's in the stomach, it would be a very safe way to rehydrate a dehydrated child for however many hours it is until they reach a district hospital.
Thank you.
Safe. You would just do it slightly slowly if they had severe malnutrition, if they were edemators. And if they were a little bit smaller, then you would just run it at a lower rate.
Good, thank you, Doctor. We have time for 2 questions more. The one is from Maria. She's asking, what are the prescripts in terms of a scope of practice of health practitioners at primary healthcare level? To example, administer oral versus nasogastric versus IV hydration while awaiting referral or transportation to the next level of care. Also, what resources would you recommend to be available at the primary healthcare with regards to an ORS corner?
So just repeat the first part of the question again, please.
So I think she's referring to the same that Marike was asking of referrals. So she's saying, what are the prescriptions in terms of the scope of practice of health practitioners at primary healthcare level? To example, administer oral versus nasogastric versus IV rehydration while awaiting referral. So I think she wants to know, is it in the scope of practice of primary healthcare level health administrators to administer oral rehydration, nasogastric rehydration, or IV rehydration?
Well, it's in the scope of practice, I think, of nurses. So nurses are trained to do IMCI, and a professional nurse is most certainly in their scope of practice to insert a nasogastric tube. And then the oral the nasogastric infusion is very simple and easy to teach. I mean, so usually when we're using it in our setting, they are just initiating the therapy, the nasogastric infusion, and referring in. They are not putting nasogastric tubes in, treating children, and then discharging them home. So it's so definitely they're all IMCI trained to give oral rehydration therapy, but upscaling to using a nasogastric tube. And it is in the scope of practice of the professional nurses who are IMCI trained to learn to put up an IV while awaiting transfer, because that is in the recommended guideline. So I think every clinic or facility is different. And I think certainly staff can be taught. And you need to look at the facilities that you refer to you, or that you work with, or that you work in, and see what is feasible. And we've had a lot of sisters cope very well. I mean, in some clinics, they're very good at putting up IV lines, and then they only want to put up IV lines, and they're very resistant to putting in nasogastric tubes. But universally, nasogastric tubes are easier to put in, safer to put in, and I think staff just need to get used to doing them again if they haven't done them for a long time. But it's certainly part of a professional nurse's training.
Thank you, Doctor. So the second last question is from Pumzile. Pumzile is asking, if you have a child that represents or presents with diarrhea due to herbal medicine, would the treatment be different, or would you use the same treatment guidelines?
The treatment is exactly the same treatment guidelines. I think the things you're concerned about with the herbal medication is other consequences depending on what was in the herbal medication. So they can get renal failure, they can get liver failure. So I mean, those children need to be examined and watched very closely to see if they don't need a referral. But the principles are the same, to rehydrate them if they're dehydrated, to give them zinc, to let them feed, to stop ideally the herbal medication because we don't know what's inside of it. And if there's any suggestion that if they are shocked, severely dehydrated, jaundiced, that they rather be referred for further investigations.
Good, thank you, Doctor. The last question is from Mohammed Kuman. Mohammed says, Doctor, thank you so much for a comprehensive review of management. And then he's asking, or he's posting a few comments and then asking a question. He's saying the use of hypoosmolar ORS has reduced hyponatremia, so use the new preparation. The question is, would you please run through the stepwise empiric protocol for management of diarrhea, which is divided into 0 to 2 days, 3 to 5 days, 6 to 8 days, 9 to 10 days, and less than 14 days, after which it becomes chronic, like Bowie's regimen and the Bowie's regimen plus. Will you be able to do that, Doctor, or do you prefer that we provide a written response to this question?
I think we'll send through a written response. Probably we would recommend that you follow the EDL guideline for primary health care and hospital level management. And they do provide a stepwise guide to once you reach day 7, what to consider in terms of the diarrhea not resolving. So should you think about lactose intolerance? Should you give a lactose-free feed? Check the urine. Start some empiric treatment for bacterial overgrowth. I think that's maybe what you're referring to. But I'll have a look at the question in the text and we can send through some information.
Good, thank you, Doctor. Doctor, they also thank you very, very much with great appreciation, Doctor. God bless you.
Thank you very much.
Yeah. So, Doctor, thank you so much. We have unfortunately come to a very informative and a very excited session. So thank you so much for sharing your knowledge and your expertise with us. We really appreciate that. To all the participants, thank you so much for participating, and also for you that stayed until the end. What we are going to do the way forward is we will write up these questions, and we will also write up the answers. For those of you whose questions have not been answered, we will also send your questions to Dr. O'Connell so that you can respond to that, and then we will also get back to you. I know, for example, Megan, you've asked about tips that doctor can give with establishing whether it is a diarrhea because of a milk allergy, or is it other factors. We will definitely pass that question to Dr. O'Connell, and we will get back to you on that. Thank you very much for attending. We will also be in contact with you when we send your CPD certificates, and in that email we will also send to you the link to this YouTube channel that we have used for live streaming, so that you can also refer back to that. And in that, if you are interested in Dr. O'Connell's contact details, please feel free to contact me, and with her consent I will then distribute it. Doctor, thank you so much for joining us, and thank you for your expertise and your knowledge that you shared. We really appreciate that. And to each and every one, thank you very much. Goodbye.
Thank you, Magda.